Very good afternoon to all of you all present here. At the first outset, I'd like to thank AIOC committee to give me this opportunity to have a talk along with all the stalwarts here. So I also welcome all my seniors and the colleagues and who are going to talk on the same topic subsequently. So, good afternoon. So, my particular talk is going to be on topography as an additional tool for ocular biometry. What is a cataract surgeon's perspective on that? So, during my talk, I'm going to cover up answer these few questions like, why tomography should be used for Iol calculation and when we can use it, then what are the things that we are going to look for, and how are we going to, apply these things into the Iol calculations. So everybody knows all these machines, which is very, very important for a good calculation of IOL power. So they are all doing well, but the special mention will be for the Iron Master 700 and the Brenstar 900, which gives us more accurate K reading and which can be applied to most of the newer generation formulae and give us the most accurate result. So when we know that we have such good optical biometers with us, why do we need tomography? Then let me just enumerate a few points out there. So there is certain terminology named as posterior corneal astigmatism, which is supposed to be one of the very key factor or important factor as far as considering the toric IOLs and considering the premium IOLs is concerned. So we should certainly use pentacam for measurement of these posterior corneal astigmatism. Then poor ocular surface will always give us irregular corneal surface and therefore the measurement errors. So we should definitely be more reliable readings will get with the pentacam. Eyes with irregular corneas and the oblique astigmatism are the conditions where, again, the repeatability is a problem. So pentacam still is better than any other biometer. So patients who have undergone post-refractive surgery, then there are certain masks we should look at. And in certain normal eyes with the low astigmatism, when we are planning LRI or arcuate keratotomy, then certainly we should use pentacam in those cases. So now that we have decided we are going to use pentacam, so we are going to use the topography or tomography for our patients, then there are various machines which are available. Then why only Shamfleck based machine has an upper edge? So because it calculates around 138,000 elevated points of the both anterior and the posterior cornea, it has the highest repeatability value. And then also there is one particular thing when it has fixation camera and it has the rotating chamfer camera, and therefore the smallest of the eye movements can be detected very soon, and the chances of error are far more lesser as compared to any other biometer available to us. So it also eliminates the inbuilt aberrations which are present in the machine itself. So that is why it is better to use. And then this is one particular study which compares the K values, which is measured by 5 different biometers and the Shamfleck tomographer. So it shows that the Shamfleck-based machines will always have the highest repeatability, and the total corneal refractive power, which is the norm in today's time to use, it is best to be used the one which we get at the 4 to 5 millimeter zone. So now that we have done the scan of of our patient, and we come to the various maps. What maps are we going to look at? The first and most important one is the indices that we look at. The quality specification has to be perfect. And the Q value is the measurement of the shape of the cornea. If it is higher, then probably this cornea is not normal or it has undergone some kind of surgery. Then after seeing the usual astigmatism values and the axis, the next important thing that we look at is the pupillary center, and the x coordinate is something which is important, which gives us the rough idea about the angle kappa. Though not accurate, but yes, it can certainly give you some idea about it. Then thinnest location is the next one we look at. Anything lesser than 470 is abnormal, and the y coordinate of the thinnest local is something which can give us the idea about the shape of the cornea or the irregularity of the cornea. So, and next important thing that we can see is the pupillary diameter. So it can roughly give us, again, not very accurate, but it can roughly give us the idea whether these patients are good for premium IOLs or not. So once we have seen the indices out there, so the next and very important map that we look at is the quad map, that is the refractive map, wherein we first of all look at the superior-inferior asymmetry and the skewing of the radial axis. Anything the asymmetry which is beyond 1.5 diameter and the skewing of the radial axis more than 22 degrees is considered abnormal. On the front elevation map in the central 3 millimeter zone, anything beyond 7 micron is abnormal. Then back elevation map, anything beyond 17 microns is abnormal. And in the pachymetry map, anything less than 470 is abnormal. And superior inferior asymmetry of more than 30 micron is considered to be abnormal. So if we get any abnormal value, the next important map that we will look at will be the Bellin-Ambrosio display map. So here it shows the enhanced ectasia map of each and every eye, and it can detect the earliest of the changes in the posterior cornea and the anterior cornea too. So the Poisson thickness increase, if it goes beyond the 2 standard deviation of the normative data, then probably this eye is having an ectatic disorder. We should look into more information about this. Another important and newer classification that has come up is the Dr. Bellin's ABCD classification, which tells us about the anterior and posterior radius curvature and the changes in it, and thinnest pachy and the distant visual acuity. So once we know that their patient is probably having an ectatic disorder, it would be prudent to tell the patient to wait for some more time, call him again, repeat the scan, look for the progression map here. And if you find any kind of progression, then certainly you would treat that irregularity first and then go ahead with the cataract surgery. So next important map that we look at is the equivalent K reading, which is usually used for patients who have undergone post-refractive surgery, and then because of the change in the Gell-Strand ratio, then these are the candidates who would benefit with the EKR values. And certain irregular and ectatic corneas can also be measured with the AKR map. So the anterior surface keratometric values are good, but they're not enough for choosing the premium IOLs because they don't take into consideration the posterior cornea. Then the corneal values, which the power values, which is based on the anterior and the posterior surface, these are the newest forms of the corneal parameters that we are taking into consideration. Why EKR is better? Because it measures the interior and the posterior corneal surface independent of each other, and it takes into consideration both the refractive indices of air to cornea and cornea to aqueous. And then after that, after adding the two, it also does the adjustment for the change in the Gell-Strand ratio, which the patient has undergone. So therefore, it gives the most accurate value where it can be utilized for the newer generation formula, which use refractive index of 1.3375, like Barrett's TK. So coming to the next important thing that we look at the zones, which is the different zones which are centered around the pupillary center. And as per the studies, it is the 4.5 millimeter zone. K values are supposed to be the most accurate one to give the best result. So either we can use this zone values directly to the online calculator, which is available to us, and calculate the IOL powers, or we can also use the EKR 65 values, the K values at the EKR 65%, and it can directly be implemented to the Holiday 2 formula, and it gives equally good result. So next important thing that we would look at would be the aberrometry. The most important and common aberration that we see is the spherical aberration. So we should look at the RMS value of the higher order aberration at 4 millimeter. And if your spherical aberration is matching with the total higher order aberration, then putting a aspheric lens possibly will help in that patient. But if your higher order aberration is not close to the spherical aberration, then possibly these patients also having coma or trefoil, and they are not the ones for the multifocal IOLs because they will have distal photoxia post-operatively. The next important map would be the pachymetry map, which in some normal eyes with the low astigmatism, where they don't fit into the category of toric IOLs, we can consider the peripheral thickness of the cornea and apply it to the LRI calculator and give the best result to the patient. So coming to summarize.
Can we summarize in the next
one? I'm just finishing off, just another one. Yeah, so evaluation of corneal cylinder, we should certainly compare with the wavefront analysis too, and evaluation of corneal spherical aberration. So anything cutoff value from aspheric will be 0.1 micron and above. And detection of corneal shapes, definitely we should look at the axial power map and quantitatively the sagittal and the front back ratio. And that is here. And the evaluation of the corneal irregular astigmatism, we should, the cutoff value for will be less than 0.3 micron for any premium IOL to be implanted. So to summarize, the topography or the tomography is, it helps us understand the shape, the type of astigmatism, irregularities, aberrations, earliest changes in the cornea, and also some residual errors if we come across, which can be treated. So thank you for your patient hearing.
Thank you, ma'am. With that, let me call upon the next speaker, Dr. Vaishal Kenya.
Yeah, before I stop sharing my screen, I would just like to introduce him. So can I do that?
Sure, ma'am, go ahead.
So I welcome Dr. Vaishal Kenya. He's the chairman and medical director of Kenya Eye Hospital, Mumbai. He's a very well-known phaco-refractive and cornea surgeon from our field, actually. And he's one of the best surgeon who has shown a lot of challenging cases in various symposia, and the youngest doctor to have to achieve the award. And I welcome him. Over to you, sir.
Thank you so much for a very nice introduction. And at the outset, I thank Dr. Somil Kothari for inviting me for this instruction course and the AIOC. So without much ado, so the talk is influence of corneal aberrations on premium IOL performance. Is my slide visible?
Yes, sir.
Okay. So why aberrations are important? So in the previous talk, we saw that topography is very, very important, but also higher order aberration is important to give quality of vision. It allows you to provide correction beyond sphere and astigmatism. Now, what is quality of vision? Quality of vision is for better contrast, for better low light vision, and all is dependent on lower order aberrations. See, mind you, if you have not corrected the lower order aberrations, then there is no question of correcting higher order aberrations. So you require an eye to achieve post-cataract surgery or near emmetropia. Then you can do the fine tuning and work on the higher order aberrations. So spherical aberration correction in cataract surgery is not something new. We have aspheric lenses to improve the contrast sensitivity, and customization is not possible with the current technology. We just have neutral, negative aspheric IOLs and spheric IOLs at the moment. So measuring aberrations, these are the various ways by which we can measure. Hartmann-Shack is the most popular one. Scherning's, differential skiascopy, and ray tracing. This is a aberration Zernickel polynomial map, which has broken down the wavefront into small components by which we can understand the wavefront, the complex wavefront, in a better fashion. So third order onwards, we usually go up to the sixth order, beyond which it is not that important. So today, the spherical aberrations which are most important are the spherical. Sorry? You can hear me?
Yes, sir, we can hear you.
Yeah. So the spherical aberration and the coma are the most important spherical aberrations contributing to the quality of vision. So aberrations are dynamic. Just to give you an example, this is immediately after a blink and 40 seconds after a blink. You can see the distortions occurring and the aberrations. So really, to measure these aberrations is very, very difficult. What we can do is bring it down to mitigate them to a level by which they are not significant. Now, what are the sources of aberrations? They're basically divided into external source. The external source is the tear film and the anterior cornea, and the internal source is the posterior cornea, lens, and the retina. The most important contributor is the anterior surface or the ocular surface, which is the tear film and the cornea. They contribute almost 90% of the total aberrations, and that's why the topography becomes a very integral part of a premium cataract IOL workup. Now, to understand the corneal spherical aberration is constant all throughout the life, but the lenticular spherical aberration, it is negative when we are born, and as we age, we reach the presbyopic age. It neutralizes the corneal spherical aberration, but later on, it adds on to the positive spherical aberration, thereby deteriorating the image quality. If you see the spherical aberration distribution, it's primarily, if you see, this is a Gaussian curve, but it errs more towards the negative or towards the positive side. Majority, almost 80% of the spherical aberration is more than 0 and less than plus 0.4 microns. Now, what we are talking about aberrations are all monochromatic aberrations. We are now also have chromatic aberrations, but by and large, these chromatic aberrations, which are about 1.5 diopters in magnitude, are neutralized to some extent by these monochromatic aberration, higher order aberrations. So most important is when to customize and when to correct is in corneas post refractive surgery, where the aberrations and the coma increase by 2 or 3 folds. This is when, if you want to put a premium IOL, this is the cases which are the non-virgin corneas, where you have to be very, very careful. Otherwise, you can have post-operatively a very unhappy patient. So, George Baiko and et al. In 2006 published a paper saying about the customization of IOL, and he said a target of plus 0.1 micron of spherical aberration would give you a better contrast sensitivity. But that concept was in 2006. And we had an array of aspheric IOL options, and those options are still the same. Mind you, neutralizing completely the spherical aberration, we are compromising on depth of focus, which is also equally important. So a balance is what is important. So mind you, it is not complete neutralization which is important. Some amount of positive or negative spherical aberration, if left around 0.1 on either side, could be fine. So ideal spherical aberration target, what another study showed was a small amount around 0.1 microns is considered to be best, and they found the pilots having a positive spherical aberration did better in visual task. But Wang and Koch in JCRS 2007 published a very novel concept. They said the spherical aberration is half the amount and opposite side of defocus, meaning the lower order aberrations and higher order aberrations interact. You cannot dissect and individualize each aberration. All of them interact and behave in each other. There is a particular machine by Pablo and Natal which measures this interaction by it measures the visual adaptics, and that is the only machine available today by which we can exactly know the resultant aberration, because the defocus also reacts and neutralizes to some extent the residual spherical aberration. So if we have a residual error of minus 0.5, the ideal spherical aberration should be plus 0.2. If a plus 0.5 diopter spherical aberration is there, and ideal would be a minus 0.3 spherical aberration. So ideal spherical aberration target varies according to the defocus and astigmatism, and this is a new concept. So we cannot have a fixed value for spherical aberration because of the interactions of the lower order aberrations and higher order aberrations, because the ocular surface, the tear film and the pupils are also making it dynamic. So post-operatively, we need to aim for near emmetropia. That is the basic requisite for correcting aberrations. And in non-virgin corneas, we need to have a customized approach, and sometimes a two-stage procedure may be required. I'm sure Saumil is going to dwell more in detail about this topic, where we can correct the irregularity in the cornea and then dwell and implant a premium IOL. So a prerequisite for a customization of spherical aberration is the near zero defocus, means less than 0.5 would be ideal, a stable regular ocular surface, which I'm sure one of my colleagues is going to dwell how dryness should be treated before dwelling to a premium IOL. And surgically, it has to be flawless optical centration and the tilt has to be taken care of. Neuroadaptation can adapt some amount of spherical aberration, but not the orientation of the higher order aberration. So dry eye need to be treated before measurements. An optical biometer is very, very important because it tells us the foveal centration, the K-Myers, the geometry of the whole eye. Tomography is important, and corneal aberrometry. I used the eye trace and the OPD scans in cases where the patient is unhappy post-operatively in premium IOLs to find out what is the cause and where the problem is. So these are a few examples. This is a post-RK case, and as Bindu said, the EKR map is very, very important. Here you can see the gross irregularity which is there. So this eye, there is a gross decentration of the ablation or the optical zone, is not an ideal candidate for a premium IOL. You can see the total is almost 4.22 and the spherical aberration is 0.481. So ideally, a premium IOL cannot be implanted. An option of regularizing the surface with a topo-guided PRK with mitomycin C can be contemplated, but that we have to tell the patients about the limitations and explain those things and move ahead. And we cannot say a total independence of glasses even after doing all these procedures. Second case is a close LASIK case where you can see an EKR map with a very good peak. So this is a map which shows the central 5 millimeters. It shows quite good regularity, and the Belen-Ambrosio bad display, the aberration profile is within limits. So this is a patient where we can implant a premium IOL.
So would appreciate if you could wind up in the next 1 minute.
These are my second last slides. So this is a post-LASIK case where again there is a good peak in the EKR map and the aberrations are quite controlled. Here also you can help, and this is how we can decide whether a premium IOL can be implanted or not. Here the total aberrations are quite high, around 0.86, and you can see the point spread function is also high. Here, mind you, the spherical aberration is not that high, but the other aberrations are high. So this again could be a problem. This is an example of an inferior steepening on a topography, but if you go and see the aberration map, the aberrations are not that significant. So you can go ahead and implant a premium IOL. So this, the workup of a topography, aberrometry, tomography, and an EKR map is a requisite in addition to an optical biometry for a premium IOL practice. Thank you so much.
Thank you, sir. Now I request the panelists to please introduce the next speaker.
I call upon Dr. Saumil. He'll be our next speaker, and he'll be talking about the mapping in corneal keratoconus and irregular corneas. So, can I share the screen for a minute? Just.
Sure. Yes, ma'am. You can go ahead.
So, Dr. Saumil is Medical Director of Bombay City Eye Institute, and he is the editor of cataract section of IGO, and very excellent surgeon and a wonderful human being. And he has attended many CMEs and conferences. Loves his dad very much, and he's an excellent quizzer. Even I have witnessed some of his quizzes. So over to you, Dr. Samuel.
Thank you, Dr. Bindu. Just while I share my screen, I'll just correct Vaishal out here, that saying that okay, this course is Dr. Bindu's course, and she's done everything, and all the participants and everything are basically invited by her. All of us are just actors. She's the director, right?
Dr. Bindu also.
Right. So cataract surgery in irregular and ectatic corneas is what I'm going to speak. And cataract surgery today, as we all know, is a refractive surgery. And the emphasis is always going to be on good quality of vision. And Dr. Vaishal has, of course, spoken extensively about what quality of vision means in terms of aberrations. Now, talking about irregular cornea, the cornea is the prime refractive surface. So as opposed to a regular cornea, which gives a crystal clear image on the retina, an irregular cornea is akin to those funny mirrors which you see, which gives rise to all these distorted sort of images. So the image on the retinal plane is not perfect. It's actually far from perfect. What are the causes of irregular corneas? Broadly, it can be described as corneal ectasias like keratoconus, keratoglobus, PMD, etc. Or post-keratoplasty, whether it be PKP or DALC, or post-corneal refractive surgery, especially in RK patients, we see quite a few of corneal irregularity, less so in LASIK and PRK. Corneal opacity and scarring, whether it be post-trauma or very commonly post-infection. Corneal dystrophies and degenerations are the other causes. So in this talk, I'll be speaking mainly about two aspects of in the whole list, that is keratoconus as an ectasia and scarring as an irregular cornea. So talking about keratoconus, it's characterized by thinning and steepening. That results in irregular astigmatism, keratometric myopia, and decreased vision. Also, it has been found that keratoconic eyes develop cataract at a younger age. Even a slight amount of cataract has a magnified effect in these irregular corneas. They have a lot of aberrations due to the lens-induced opacity. So we should be aiming to correct the cataract earlier as well. So it starts with preoperative analysis, and keratometry is one of the main concerns because there is absolute more variability in our keratometry readings. It's very difficult to get a good keratometry. It has been found by a study comparing 5 devices that in mild keratoconus, there was good repeatability of all these 5 devices. In moderate keratoconus, that is 50 to 55 diopters, the pentacam showed a higher repeatability than the others. And in advanced keratoconus, no matter what the machine was, they all showed a poor repeatability. So in advanced keratoconus, standard case may sometimes yield better results with a slightly low myopic target than the actual keratometry readings. What about Iol power calculation? Irregular anterior and posterior surface has a very unpredictable impact on Iol power calculation formulae because all the formulae have a standard ratio of anterior to posterior curvature, and this is completely altered in keratoconus. Also, keratoconic eyes may be longer with deeper anterior chambers and thus making the effective lens position prediction difficult. It has also been found by some studies that the SRK2 formula yielded better results than the SRK-T. But of course, newer generation formulae may be more accurate. Coming to the IOL selection, monofocal IOL, the standard monofocal is the IOL of choice. Avoid multifocal IOLs altogether in irregular corneas because it certainly adds a compounding effect in terms of aberrations. Toric IOLs may be implanted in selected cases. Mind you, this is monofocal toric IOLs. And because of the aberration of the cornea, prefer neutral aspheric or zero aspheric IOLs compared to the spherical or the negative aspheric IOLs. So that it does not add or add on to the spherical aberration of the entire eye, and especially the cornea, as Dr. Vaishal was saying. There are specific indications of toric IOLs, which I would just tell. It should be implanted only in stable, mild form of keratoconus, not in the advanced form. The manifest axis on refraction should be more or less plus or minus 10 degrees of the topographic axis. And also a note that avoid toric IOL implantation if the patient is, if you're planning for a contact lens correction post-operatively, because the patient sometimes has a pre-operative contact lens with a good vision before cataract develop, and they might be planning to continue with their contact lenses post-operative. In such cases, avoid toric lenses. Now, intraoperative considerations are basically incision related and visibility related. Now, coming to the incision related considerations, place the incision away from the cone. That is, place the incision in the thicker part of the cornea. Basically, if you have an inferior cone, avoid inferior or inferotemporal incision, go more superiorly or superiotemporally. Also, if there is scarring in advanced cases, it's a good idea to place the incision 90 degrees from the scar rather than 180 degrees, because if you place it 180 degrees, you will tend to have the phaco tip going towards or beneath the scar. So it'll be obscured and the visibility will be an issue. So place the incision 90 degrees away from the scar rather than 180 degrees. Also remember that these corneas are biomechanically weaker than normal, and hence the incisions may leak. It's a good idea to suture these incisions if required. And the SI is of course unpredictable. Visibility related considerations is scars, of course, obscure visibility, and use a focal illumination source rather than a diffuse microscope illumination. Using HPMC to coat the surface will not only smoothen out the surface, but also magnify to a certain extent. So it'll give you a good outcome. And it has also been described the use of Rgb lenses on the cornea during surgery. So this paper was that they used in two cases, they used a sterilized Rgb lens, and they found that in all steps, the visibility becomes better. Also remember to stay in the anterior lens capsule for better visibility, because these corneas are irregular or they may be scarred. Post-operative management is in terms of contact lenses will give you, of course, a good visual outcome, especially if they are having good pre-operative outcome with contact lenses. And aim for a low myopic post-op refraction always, because not only will that aid in the near vision, but it will also facilitate scleral contact lenses wear. And for unacceptable refractive surprises, IOL exchange or piggyback IOL should be considered. So the treatment algorithm which I would propose is patient having keratoconus with cataract. If you go down the left eye, it's history of good corrected visual acuity. And if the manifest axis is equal to the topographic axis plus or minus 10, then implant a toric lens. But if the manifest axis is not equal, then just go ahead with implanting of the monofocal IOL. On the other hand, if they have history of low corrected visual acuity, then you can try regularizing the cornea by intracorneal ring segments or topo-guided PRK, and then followed by cataract surgery with a monofocal lens. Of course, in advanced ectasia, you go ahead with a PKP triple, right? So coming to corneal scars. Corneal scars, just remember that if it's a superficial corneal scar, you go ahead with PK to remove the corneal scar. It smoothens the corneal surface and improves the visibility by making the scars less dense. For deeper scars, you can go ahead with a DALC or a PKP triple. Always do remember, if it's especially a post-herpetic scar, then antiviral prophylaxis should be initiated before surgery. Just to have the points which I was talking about, focal illumination in terms of either keratoconus or scarred cornea, it really improves the visibility. Also, if required, do use iris hooks to dilate the pupil if needed. Stay in the capsule. You can see that with focal illumination, there's definitely a better visibility as compared to the diffuse illumination. And just to conclude, I would say planning is the key to success in cataract surgery in irregular corneas. and patient counseling becomes very important in view of unpredictable outcomes. Thank you very much. I thank the panel and thank the IOS and Dr. Bindu in particular. Thank you.
Thank you, Dr. Somil. Now I call upon the panelists to introduce the next speaker.
A question. Can I interrupt? I have a question for Dr. Somil.
Sure.
You use the endo illuminator from outside, or you use it through the side port?
So it can be used either ways. Either you can just hold it at the limbus or near one of those positions,
externally,
or you can just insert it through a 20 gauge or 22 gauge side port sort of a thing. So it's a slightly wider opening rather than a 20 gauge. So you might have to increase it, but it can be used inside the eye as well.
Okay, thank you.
Just before you start, Dr. Karishma, I'd like to introduce welcome, Dr. Karishma. She is Medical Director of Jihan Eye Clinic, and she has completed her basic course from Bombay City Eye Institute, has done her fellowship in Narayan Netralaya, and she has lectured in various national and international conferences, and an excellent surgeon that I know of. So welcome to you, and over to you.
Thank you, Dr. Bindu. So while I'm uploading my presentation, I completed my DNB from Bombay City Eye Institute, where at that time, back then, we used to use a very personalized way by Dr. Kulin Kothari to use calculations for post-refractive cases. Then I went on to do my fellowship, where I learned a totally different method. And after my fellowship, I happened to have another IC in the next year with Tanvi, where she uses a completely different method for post-refractive Iol Power Calculation. So the take-home message at the end would be you have to do whatever floats your boat and whatever gives you the most predictable result. But for now, I'm going to speak on what technique I use most frequently and what has worked well in my hands. So the tools required for, can you see my slides?
Yes.
Okay. So the tools required for calculation of the IOL power of any post-keratorefractive surgery would first of all be topographic data, like Dr. Bindu has already highlighted. An IOL master or a lens star, basically optical biometry, would always be preferred if available, especially in metro cities where now they are even available on rent. Even if you don't own one, you can always call for it. Otherwise, you should have a constant, accurate immersion biometry, ideally, otherwise optical biometry. If available, pre-LASIK data is best to have. So being a refractive surgeon, what I do for all my LASIK patients is I give them an entire file with their pre-LASIK IOL master as well as their pre-LASIK topography fed into one sheet. And a year after the LASIK, when they come for a regular follow-up, I do the entire workup again, which includes the topography and an optical biometry, and I feed in all that data into a separate sheet and again give it to the patient as their post-LASIK data. This is the post-LASIK data which is stable after 1 year of surgery and prior to the development of cataract. And lastly, what I use and what I'm going to be talking about is the use of the online Iol Power Calculator. So what to do when the patient comes in your OPD? Check, first of all, do you have access to topography? Do you have the topography yourself? If yes, you do it. If not, please do not hesitate to refer, because you would need a topography in a post-keratorefractive surgery patient for sure. All right, you go on to the Iol Power Calculator on ascrs.com. So this is the calculator that I have used and what I have got most accurate results with. And it shows you, once you click on it, it shows you the option of prior myopic LASIK or PRK, prior hyperopic LASIK or PRK, and also prior RK. And it also tells you with each update that it itself undergoes, it tells you what all it has changed in the formula, what formula it is no longer using, so on and so forth. So this is what the entire screen would look like for a patient of prior myopic LASIK or PRK. Initially, there's the patient data, there is pre-LASIK data. If you don't have it, you can just leave it blank. And then there is post-LASIK data, where you enter your refraction and you enter your topography. Now in this here comes the importance of the topography. It does not matter which topography machine you have access to. Even if you are sending the patient elsewhere, whatever machine they are having, they will have these particular display on their machines, and you can just request them to send you that particular printout. So that is what you need to make sure is done, after which you enter your immersion biometry data. So if you have access to topography, no matter what your topography is, starting from Placido to shine plug, scanning slit, OCT, you can just feed in your data. I'm not going to waste too much of time on this because Dr. Bindu has also covered a lot of it. So there are different Placido based machines. Each of your machine will have that particular value. For example, in the older machine like ISIS, which is a Placido based machine, there is an effective refractive power which comes on a holiday diagnostic summary. So sending your patient who has this machine, you ask for this diagnostic summary, and in the left bottom corner, as you can see, there's something called effective refractive power. This is what you need to feed in into that calculator. So the point is that you should know which data to pick up from which display image and feed it into the calculator. If it's an atlas, for example, then you have your, it asks you for your 4 mm zone values, and this is how the display looks like. So you need to pick in the ring at the value at the 4 mm zone. Similarly, for TOMI, you have the anterior corneal curvature power map, and you take the value from that. After this, when you have fed in your data, including your topography and your biometric data, it shows you the IOL power calculation and how it is done. So on the left, it will show you using delta MR. So in case you have your manifest refraction, then the difference in manifest refraction formula will show you the values on the left. In this case, I did not have any. And on the right, using no prior data, what formulas it used to give you a value. At the end, it shows you an average IOL power in minimum, maximum, and average. So usually what we do is we always take the average power, rounded it off. So if it's 21.17, you round it off to 21.5. And then you further go on to plan whether you are going to target myopia or not. On the shine plug imaging, this is of a Sirius, but you can also use, so though I have used a Sirius map on the pentacam value which has to be entered in this calculator, later on me and my colleagues from Narayan Netralaya went on to show that these values should not be interchangeably used. Okay, so all these values can be fed in from whichever respective machine you had. Like Dr. Bindu already mentioned, you can take in the TrueNet power from the EKR map on the pentacam, which is most reliable. And finally, you get your IOL power. So let's move on to examples. My first example is that of a 60-year-old lady who had a LASIK done many years back and was now having immature cataract, and she wanted spectacle independence. Now, I access back then to the CSO Placido topographer. So I got her topography done. We're looking for two things, like already mentioned by the previous speakers. We're looking for a uniform central zone. We're looking for any irregularity. And of course, we're looking for the actual K value. So this was her right eye and this was her left eye. Now, when I got her IOL master done, and if you, what I'm trying to highlight here is that if you see her values on the IOL master, the first value in the right eye for an IQ lens was 20.0 and 20.5 showed me a myopic overcorrection of -0.4. In the left eye, 19.0 is what the IOL master was suggesting. Now, if you go to the calculator and see, when I have entered her data into the calculator, in the right eye, it shows me 21. So as opposed to the previous IOL master, which was showing 20. So a 1 diopter change is what it shows. All right, in the left eye, I put in a toric lens because she had a little of astigmatism. And these were the powers that are ultimately used. Post-operatively, if you see her in early post-operative phase itself, she had hardly a -0.5 myopia on the autoref, and her vision was unaided 6.6 and 6.9 respectively. She went further back to the US and her vision was maintained. Case 2 is a post-RK patient with LS2 and posterior cortical opacities. This was the topography. Now, very important, the central zone is again regular, which is what you want to look at. These cases are very tricky again. You have to look at the refractive equivalent power map and take the value from there. This is what it looks like. So you have to take into consideration that the 4 mm value has to be taken. So the mean pupillary power is what you will enter into your calculator, in this case 38.28. So once you have entered that data, it shows 3.9, rounded off to 4. We did an uneventful phaco emulsification, but we got a post-op surprise of 2.25 with the slight cylinder on day 1. Now, if you see the way it progressed, it reduced over a period of 3 months. So the take-home message is that you do have transient hyperopic shifts in post-RK patients. Because their optical zone is much smaller, you always try to target a little more myopia. So what I do is I usually target a -1 myopia and take a slightly more limbal incision than a complete clear corneal incision. Also, be always ready for any of the incisions opening up. So explain that to the patient and always have a suture ready on standby, because the gape of the pre-existing wound may happen at any point during your phaco. Also try to keep your parameters as low as possible. So in summary, you do require a topography. If access to an optical biometer is available, that would be ideal. And most important is counseling your patient to not have unrealistic expectations so that you are saved the trouble at the end of the surgery. Thank you very much.
Thank you so much, Dr. Karishma. Yes, Dr. Bindu, you can introduce the last speaker for the session.
Yeah, I'll do that. May I invite Dr. Tanvi? She is the consultant in the Department of Cataract and Refractive Surgery at Lakshmi Eye Institute, and she has done her fellowship at Netradhama Hospital, and a wonderful surgeon. And apart from her refractive surgery excellence, she also is a good baker and mother. So that's another talent she has. So over to you, Dr. Tanvi. She's going to talk about the dry eyes.
Thank you, Dr. Bindu. Thank you to AIOS. And I think we have a wonderful group here. Just if you could tell me if you can see the screen.
Yes.
Yeah, okay. So good afternoon, everyone. I'll be talking about dry eye and the problems related to that while assessing patients for cataract and refractive surgery and how we can deal with them. So a dry topic indeed, but please bear with me. The Tear Film and Ocular Surface Society has defined dry eye as a multifactorial disease. We know that the pathway has, ultimately leads to a hyperosmolarity and then ocular surface damage. And of late, we have been talking a lot about dry eye. As a clinician, I am encountering many more dry eyes patients than I was before. And let's see why. So a study which was done by Stapleton and Tear Film Ocular Surface Society in 2017 found that the prevalence of dry eye was more common in Asians. It increases with age, as we know, and it was seen to be 3 times more common than diabetes. And in their study, they found that dry eye existed in 31% of patients. So I think the real reason for this increase in cases is that we are actually looking for it now. Our clinical protocols do include tests which can pick up even a subtle dry eye. But why do we need to look at dry eye? We were fine for so long. What's the big deal? So what has changed is the mindset of the patient as well as the surgeon. Technology has advanced so much that we're now chasing the 2020 line. We have the sky to offer to the patient, and the cost of surgeries have increased, and so have the expectations. So this warrants a need for us clinicians to be very thorough, to be overcautious, to look for dry eye and take sometimes even preventive measures to avoid it. Now, dry eye affects the lacrimal tear film, and let's see what really happens. A normal tear film thickness ranges from 6 to 20 microns. This contributes to around 43 diopters. Now, if the tear film thickness decreases and if it reduces uniformly, then the change in the power of surface is minimal. But if this happens irregularly, then the change can be as high as 1.3 diopters. And also along with it, it brings a lot of higher order aberrations. A single blink normally causes a variability of just 0.1 diopter, but an unstable tear film could make it almost up to 1 diopter. Now that's a big problem, right? And an irregular tear film we know causes a light scatter because of the higher order aberration, ultimately degrading the visual quality. This is the impact of tear film which we may miss. Now, an easy way in the OPD to just see this is to put a fluorescein drop in the eye. If you look at the scan, you know that this tear film is unstable, it is irregular. This is going to give us an inconsistent reading. It will affect the refraction. It will cause a higher risk of postoperative dry eye. It will slow the healing, and all of which leading to a poor quality vision and an unhappy patient. So imagine if you are planning for an advanced refractive surgery like Contura on a patient where the core of planning are the topolizer scans. And if the scans are variable or incorrect, we will have a refractive surprise. So we'll have a patient blaming us when it was really his eye, which was dry eye to begin with. We know it causes dry eye, causes multiple issues. It affects the patient's satisfaction. It impedes a good measurement. And that is the core of our management, right? So it's a garbage in, garbage out situation. Let's look at some examples how dry eye affects our measurements. Now, this is the topography scan of the same eye, but showing two separate cylindrical errors as well as different axes taken few days apart. Now, in such eyes, it is a good idea to go back and look at the raw data just to see if the quality of Myers is good or not. In this case, you can see on the left, it shows irregular Myers. There is a sign of dry eye. There is a dry spot there. But what's to note is that both these images will give us some reading. So if we haven't gone back and looked at the raw data, we don't really know whether it was a good quality scan or not. And we may choose the wrong scan. We have a lot of tests for dry eye today, and we've added an ocular surface analyzer as well as the AIOC in our practice. We have seen that AIOC is a good tool to study the epithelium because it has piqued our interest, since that's the layer which primarily is getting affected in dry eye. This test, being a non-invasive one, also gives us a good measure of the tear film without actually disturbing it. Now, these are three examples of patients starting from the left to right, from a no dry eye situation to severe dry eye. Here you can see that there is some epithelial irregularity with thickening in some areas and thinning in some. And even in patients on the left with no ocular symptoms, the epithelium still showed some changes. And this can affect our data collection. So we need to look for it. I'll be discussing two cases to just show how dry eye affects our planning. This was a 60-year-old female who came for cataract opinion. She had a history of dry eye, but had minimal symptoms and was on occasional lubricants. Now, since she was to undergo cataract surgery, her lens star was done as well as a Varion. Now, both showed a high cylindrical error in her left eye. It is always a good idea to look at the raw data to make sure of the quality of scan, like I said. So we did have a look, and as you can see, the LED reflections are not precise. Some of them are more dark and lighter than the others. Now her topography was done. This showed a cylinder of 0.9 diopter in her right eye, and this is a tangential map of the right eye, and a 0.2 diopter in the left eye, and both show a very irregular astigmatism. So now we know that all the three machines are showing different magnitudes of axis of the astigmatism. On clinical examination, she showed signs of dry eye, and the ocular surface analyzer confirmed the same, showing a picture of a mixed dry eye. And to our shock, this was her epithelial map. Severely thinned out epithelium showing an irregular pattern. Now, this gave rise to an irregular topography, resulting in an irregular astigmatism. This is also just to show that in the left eye, not only was she had come for cataract, right? Her left eye did have enough cataract, but also the cornea is showing a very poor image quality. So even though we may correct her cataract, she may still have poor vision because of her cornea. Now, we had a previous scan of hers from 2 years back, and we compared that. The cylinder had changed from 0.5 diopters to almost 2.5. Now, this change was due to her dry eye and the ocular surface damage. Now, if this was missed clinically, or if a topography was not done, then the toric IOL would have been implanted simply based on her lens star reading, and that would surely have landed us in a refractive surprise. Then let's go to the last case, which is a refractive case, a 27-year-old boy, moderate myope, who had come to me to undergo Contura. He had no symptoms of dry eye, and on examination, his Schirmer's surely was low. But when I looked back at his refraction, his right eye would sometimes correct up to 6.6 parts or sometimes 6.9. So this was suggestive of a fluctuating vision. Now, this was his anterior segment epithelial map showing severe epithelial thickening in the central 5 millimeter zone in his right eye. And then when I went ahead and repeated his refraction, sometimes he was accepting cylinders even up to 1.5 diopters just to see 6x6, which he didn't need at all before. His ocular surface analyzer showed a mixed type of dry eye. So his topography, which was done on the first visit, was fairly all right. It didn't show any stark red flags. His topolizer scans, which I did for the Contura, were very variable. They did have a lot of tears, dry spots, and variable from one and another. And therefore, he was advised treatment for 3 months, which he underwent. And then we did his topo scan again. So as you can see that the topo scans are fairly regularized and there was a small change too. Now, this is his epithelial scan after 3 months, which seems much more regular. Now, at this point, you can take a decision to undergo refractive surgery or not. Now that we know the impact of dry eye on our measurements and thereby on our results, we have to plan for a treatment strategy for these patients. So when a patient with cataract comes with low vision to us, it is imperative to see if the dry eye related vision loss is simply because of, the vision loss is because of dry eye, or is it because of the cataract? We have to be more aggressive in our diagnosis and treatment, and sometimes even start a lubricant before surgery as a preventative measure. And differentiating the type of dry eye gives us a better treatment profile, and always set a set protocol. We have, if a patient comes, we know these are the things to do so that we don't really miss anything. There are many algorithms that you can use. This is a good one by Tearfilm Ocular Surface Society, and so is this by the ASCRS Society. They are both very practical and can be used in our clinics. Lastly, can be divided as a basic one, something which is procedure related, and also other one requiring systemic medication. So we customize it in our clinic depending on the type and the severity of the dry eye. So my take home message is that seek and you shall find. Most of our patients do have dry eye. We can only diagnose it if we look for it, and glancing at the raw data can really make or break our measurement. So remember to look at that. And I think always better, everybody says so, to look at more than one machine to look at the same data. You will have a better picture. And if you find a dry eye patient, then wait, be patient, treat them, counsel them, and then you can do any kind of procedure. So I think that is the secret to a happy patient. Thank you so much.
Thank you, Dr. Tanvi. It was a wonderful talk. So I don't see any questions in the chat box. And do we have time?
We have still 2 minutes to go, because 1:30 we will start with the next session.
Literally 2 minutes. Okay, so we can discuss amongst ourselves. I'd like to ask Sir, Dr. Vaishal, how do you manage the cases of halos or glare the patient comes with the complaint of? So, can you hear me, sir?
Yeah, I can. So
yes.
Whenever you're talking about halos and glare, primarily this is where the aberrations are affected. So as Dr. Tanvi said, we have to check the common causes first. The dryness is one of the commonest causes which has to be checked first. So sometimes glare and halos can also be because of aberrations caused because of tear film. So you need to first work on the tear film before you have a stable tear film. You cannot treat those glare and halos. The other method by which I modulate the aberrations is by giving alpha-GAN or brimonidine for decreasing the pupil size. So the aberrations or the glare and halos will be less. And if you have done a proper pre-operative workup, and then you may not face such surprises. But even though if you face such surprises, then first stabilize the tear film. Second is, if after stabilizing, if it's not fine, then you use brimonidine. If still not good, then you see for aberrations, and if those aberrations on multiple times have the same reading, then you can go ahead and treat them. This is my algorithm which I follow.
All right. Thank you so much.
Thank you, doctors. It was a wonderful session, and hearing to all of you was a treat. Thank you so much. So let us go with the next session, upcoming session. So I request.
Thank you, everyone.
Thank you.
Thanks a lot.
Thank you all.
Thank you, everyone.
Yeah.